Okay, just a quick video on resources here and a couple ideas. If we do get low on anesthesia circuits, you can use the respiratory circuit from upstairs that they use on the regular vents. You can see it does hook up here. There's a little plug that you have to plug here. Make sure that's nice and tight. You won't use this line, obviously, and you have a little adapter there that you can plug in your, your gas sampling line. Now, what I'm thinking about is, what if a patient comes in and you have to do emergency surgery on them and you're worried about them and they're acting like COVID symptoms or whatever, but you have to do emergency surgery. How are we going to manage that here? So obviously that's somebody you're not going to want to bag hardly at all. You just want to put them to sleep and intubate them right away and to minimize exhalation. And that might even happen in the ER if the ER becomes worried about them. They're intubating people early now. If they're worried, they're going to intubate them, mostly just to isolate the potential contamination. So if you have to give a neb, they're saying don't give nebs because you have to break the circuit open, and that's a big break in the circuit. This little adapter here you can use to give an MDI, and so here's the inline MDI adapter, and the MDI, of course, we have to cut off the little mouthpiece just like you normally do. But so what RT is talking about doing is they're talking about if they do have to break their system, they're going to stop ventilation, clamp the tube, and then make their change, and then unclamp the tube. So I think how to work that in our situation is, if you have somebody worried about, go ahead and hook it up like this, and then if you do have to give an MDI, then you have bronchospasm, whatever you need to solve, stop ventilation, clamp your tube, and this little cap pops open here, and this will allow air to escape. Okay, this is just an open hole that goes down inside here, and so that's the adapter from there to there between my fingers. You can see it, and then this does not hold this securely. It just kind of puts in. It doesn't. It kind of wobbles around, and you can see it pulls out really easily. So I think what I would going to do is just hold this in place, unclamp my tube, go ahead and resume ventilation, kick the vent back on, and then with inhalation, give a couple puffs, or give however many puffs you're going to give. Stop ventilation, clamp the tube, take this off, and go ahead and cover this right away. Okay, obviously this is going to be a two-handed operation, not a one-handed uncoordinated operation. So, and then unclamp the tube again, and then resume ventilation, resume your care. I think you can safely do that exact thing if you don't have this adapter with the regular 60 cc syringe and this right here, just like we normally do, but I do the same thing, clamp the tube, disconnect the gas sampling line, screw the syringe on, unclamp the tube, resume ventilation, give the puffs, clamp the tube, stop ventilation, clamp the tube, unscrew that, put the gas sampling line back on. Obviously, that's contaminated. The syringe is contaminated. This is contaminated. That could follow the patient, I'm assuming, but it may just be better to throw it away. And then, obviously, change your gas sampling line, because this isn't protected, the gas sampling line here at all. And then this filter is good for 24 hours. That question came up. That's what the manufacturer recommendation is. Okay, so I'm going to go ahead and get a couple of these in the rooms, and just so you have them in there. And hopefully all this blows over and we won't need any of this stuff.